pleasure being here. And Kim, thank you very, excuse me, thank you very much for organizing this one, which is relevant to everyone in this room, is just some of the past studies and present research that's going on in testis cancer, not just as far as treatment is concerned, but also the effects of the treatment itself, both socially, medically, and many things that Yusuf Apathy was mentioning during his talk. So in this country, as opposed to Bahrain or Saudi Arabia or Ireland or New Zealand, where you were at, we see about 8,000 new cases annually in the United States, and it makes up about 1% of all male malignancy. And I want to contrast this with the Testicular Cancer Awareness Foundation that, Kim, thank you very much for organizing this. Every October is Breast Cancer Awareness Month. So for every testis cancer patient, there are about 25 breast cancer patients. And every disease and every patient has their own story and their own legacy to follow. But testis cancer is really different than breast cancer, different than lung cancer, different than prostate cancer, different than anything else that we're dealing with. In the breast cancer community, and there's no such thing as a good cancer, but in the breast cancer community, for many decades, you have a peer group organization that you can share your stories with. When someone is newly diagnosed with testis cancer, as Yusuf was talking about, you often are alone. You don't have a peer group in your hospital to discuss issues that you're dealing with. You're just starting at your career either in school or academically in your job. If you're single, you're just starting into having romantic relationships and dating. What do you tell the person that you're dating? So it's a very unique and different breast cancer. And as mentioned, this is a young man's disease. And yes, we see people who are 5 years old and people who are 70 years old. But the great majority of patients are teenagers and in their 20s and 30s, truly in the prime of their life. And fortunately, despite the stigma, if you will, about having any type of cancer, this is also a very different cancer because we cure the great majority of patients. When someone hears the word cancer, there's often a pervasive sense of pessimism, and even how do you talk to this person? Oh my gosh, they have cancer. Are they going to give me cancer? Are they going to die from the cancer? What kind of words can I tell them for comfort and sympathy without seeming to be really kind of obsequious to what they're really going through? And as we'll talk about also, this has become a model for looking at the late consequences of chemotherapy, because we have the luxury, if you will, of having a curable disease where, again, the great majority of patients will survive their disease, and then facing the issues that happen, as Yusuf mentioned, that happen post-treatment, unless the history involves you yourself. So this does involve you. So when I was Dr. Al-Khatib's age, as a teenager in my early 20s, a drug that was used routinely for metastatic testicular cancer is an old drug called actinomycin D. It's still used in the pediatric world for sarcomas and other types of cancers. And even back in the early 1970s, if a young man had metastatic testicular cancer, about 5% of them were cured. And that was 5% higher than we were curing other types of cancer at that contemporary period. So in the early and mid-1970s, several other cancer drugs became available, vinblastine and bleomycin, that individually had the same results as actinomycin D, curing about 5% of young men where the disease has spread to retroperitoneal lymph nodes or spread to the lungs. And there was a discovery that combining the two drugs, vinblastine and bleomycin, so if you combine two drugs that have a 5% cure rate, you're going to get about an 8 to 10% cure, 5% cure rate, and that's a nice human clinical model for what we call synergism, where 1 plus 1 equal greater than 2. But truly what revolutionized the cure of this disease was the discovery of the first heavy metal ever to be used as an anion neoplastic agent. Its long name is cysteamine dichloroplatinaum, or simply cisplatin or platinum. So in 2019, much like in the early 1970s, in the field of medical oncology, we are always doing experimental clinical trials and looking at new drugs, new molecular target agents, new forms of immunotherapy to see if it can make a difference in an individual and hopefully globally in an individual type of cancer. So we get very excited if we're using a new drug as a single agent and we see a sprinkling of activity with stable disease for a couple months before progression or a partial regression of size and number of pulmonary metastases. But platinum was different. Even in patients who progress after actinomycin D, who progress after vinblastine plus bleomycin, as a single agent in 11 patients, it produced 3 complete remissions. Complete remission means disappearance of all pulmonary nodules on a chest x-ray, disappearance in all enlarged lymph nodes on an abdominal CT scan, and normalization of tumor markers with HCG and alpha-fetoprotein, and another 3 partial remission, which means, of course, partial but not complete disappearance of metastatic sites. However, this was single agent therapy as third-line therapy, and all 11 of those patients died within a year of starting cisplatin. But at least open before, looking at a new mechanism of action, a new type of therapy as a heavy metal that can be combined with other drugs to develop a successful combination chemotherapy regimen. Now in 1974, when we started out at Indiana University with this regimen, the principles then and now for combination chemotherapy remain the same. You want to have individual ingredients that are effective as single agents. They're all effective as single agents. You want drugs that have different mechanisms of how they kill the cancer cell. So these are drugs that have their own unique mechanism of action. If you're combining 2 drugs that kill the cancer cell by the same mechanism, you get additive toxicity, not additive therapeutic efficacy. You want drugs that don't have the same side effect. The major dose-limiting side effects during chemotherapy is low white blood count and potential for infection. That isn't what bothers patients. What bothers patients is hair loss and nausea and vomiting, sores in the mouth, and a variety of other acute side effects. But the dose-limiting side effect is usually vinblastine, which allowed us to give all 3 drugs in full dosage as if they were single agents. And then lastly, we want to have synergism, which was demonstrated with vinblastine and bleomycin. And one of the really unique things that has never been replicated that's true with cisplatin, it is synergistic, not just with vinblastine and bleomycin, but virtually every anti-neoplastic agent that one combines with cisplatin. So this was our rationale in 1974. Now, in 1974, I wore a younger man's clothes than I'm wearing now. And in my youthful exuberance, I never would have dreamed that introducing a then experimental drug would so change the course of a disease. We went from a contemporaneous 5% cure rate with actinomycin D to basically a 70% cure rate by introducing an experimental drug, platinum, and combining it with a relatively new but established synergistic 2-drug regimen, namely with vinblastine and bleomycin. So this was 1976, and in 1976, the field of oncology is very different than it is now. Not only was there the public pessimism about cancer, but professional pessimism about what we can do with cancer as well. This was a very toxic regimen, and questions came up about what we were doing with this therapy. Were these going to be durable remissions? And by 1976, when this study had ended, we had at least convinced ourselves that the main benefit with this high cure rate. So we then did a series of clinical trials. A clinical trial is done to answer a relevant question. So study number 2, we reduced the dosage of vinblastine, which will always mitigate the side effects from an individual drug, but will it achieve the same cure rate? And the answer was yes, it did. And then in study number 3, which is one of our more important studies, the dogma in the 1970s and 1980s in most oncology was that you would treat patients with aggressive therapy and then continue a single drug for up to 2 years of therapy. And that was done in study 1 and study 2. So in study 3, we challenged that concept because we felt that the valuable drug was not the vinblastine, not the bleomycin, but the platinum. And the platinum doesn't lend itself because of side effects to give for a long period of time. So after 12 weeks of therapy, we randomized 147 patients to get or not to get an additional 2 years of therapy with vinblastine. And there wasn't even a 1% benefit by that additional 2 in Indianapolis. It will work in Denver, it will work in New Zealand or Ireland or Saudi Arabia or anywhere else in the world. So this is data by our National Cancer Institute where they do demographic studies. So in 1974 is when we first presented data with platinum, started with platinum valvampleomycin. In 1976 is when we first presented the study, and in 1977 first published it in a peer-reviewed journal. And I like to say that we can make these type of significant achievements in other type of cancers other than testis cancer. We deal with significantly improved quality of life and quantity of survival. But we've never with other cancers have had such a rapid improvement in the cure rate overall with all stages of disease, especially with metastatic disease where it went from 5% to a current 80% cure rate. Well, just to quickly go over some of our 1970s patients, this is a patient who came to us critically ill, very short of breath, and on his lateral view of his x-ray, white is cancer. There's almost no normal bladder or lung in here. And without his disease other than testis cancer in 1975, we would have entered him in hospice, but this was testis cancer, and he's long since been cured 40 plus years out. This is one of our patients with what's called choriocarcinoma, again with massive replacement in his lungs, again long since cured of his therapy, dating to 1980 on this particular patient. And this is one of our patients with an abdominal CT scan. This is the liver, and all these dark areas in the liver represent metastatic inguinal carcinoma. He also had extensive pulmonary metastases. Again, with chemotherapy, everything disappeared, and he has remained continuously disease-free despite very massive metastatic burden. Okay, so we did this first study as a phase 2 study from 1974 to 1976, which forevermore introduced platinum and changed the course of a disease. From 1976 to 1978, we lowered the vinblastine dosage. From 1978 to 1981, we got rid of 2 years of maintenance therapy. In the late 1970s, we were investigating another chemo because I mentioned that platinum is synergistic with many chemotherapy drugs, but it is more synergistic with etoposide than any other drug. So we did our first study with etoposide, what we call single agent homework. We looked at etoposide in patients who were not cured with platinum vinblastine bleomycin, and we demonstrated activity but no cures. So we then wanted to see those patients who were not cured with platinum vinblastine bleomycin, can we give them further platinum? And as it was done and published in 1985, so over 30 years ago, and we actually cured about a quarter of the patients as second-line therapy. And this is the first time that an adult solid tumor had ever been cured with second-line chemotherapy, in this case with platinum plus etoposide. Sorry. So with that as a background, the next study we did, we wanted to see if we could promote etoposide because we thought it might be a better drug and easier to combine with platinum than vinblastine. So in order to answer that question, the control arm of platinum valvampleomycin with the lower dose of vinblastine and no 2 years of maintenance therapy. The other half of the patients get the identical therapy, but it's a one-on-one substitution of etoposide for vinblastine. And this study demonstrated that not only did we have less side effects with etoposide, but as you can see on the bottom line, we had a 12% higher cure rate. So when this study was done, PVB became a part of historical history rather than anything that is currently used for young men with metastatic testicular cancer, based not upon hypothesis or subjective reasoning, but based upon data and evidence-based medicine. Well, over these first several years, we recognized the difference between those patients that we do cure and those patients that we don't cure. And certainly those before-after pictures that I showed you that were so dramatic and were cured, the majority of patients that have such massive disease were not cured with chemotherapy. And so we risk stratified with risk. They all had distant disease and lymph nodes in the abdomen and the lungs. Good risk disease, which has over a 90% cure rate, intermediate risk disease, which has over an 80% cure rate, and what we call poor risk or advanced disease, like those before-after pictures that I demonstrated, that would have about a 40 to 50% cure rate with initial chemotherapy. So the next study that we wanted to do was a good risk disease. We wanted to ask, do we really need all 4 courses of BEP? Because these patients had relatively low tumor volume and low amplitude of the tumor markers with HCG and AFP. So in order to answer that question, again, we randomized patients to a control arm of BEP times 4 versus dropping the last 3 weeks of chemotherapy. And this is not just elimination of a course, but this is dropping the most toxic course because of the cumulative side effects that we see with bleomycin and cisplatin. And once again, we were gratified to note that the number of patients showing continuously no evidence of disease, not even a 1% difference between 9 weeks of therapy versus 12 weeks of chemotherapy in this study. So over a 13-year period of time, from 1974, when the very first patient got platinum Velvan bleomycin, to the end of that 3 courses versus 4 courses, we went from treating everyone with 2 years of therapy to eliminating maintenance vinblastine and stopping at 12 weeks, to demonstrating that we get less toxicity and a higher cure rate by substituting etoposide for vinblastine and can be cured, not with 2 years of therapy, but just 9 weeks of chemotherapy. Well, not all clinical trials that we do are successful. Another cancer drug that is and was used in testis cancer is ifosfamide. Now, ifosfamide is a drug that is going to have a lot more side effects than bleomycin, but it's an interesting drug. So we wanted to see if we can substitute ifosfamide for bleomycin, and this is BB16 ifosfamide platinum versus BEP. Again, it's a one-on-one substitution, dropping the bleomycin in favor of the ifosfamide over here, knowing that VIP is more toxic, but hopefully it has a higher cure rate. Well, 283 patients with advanced poor risk disease were entered on this study, and although the numbers are slightly better, these differences are not what we call statistically significant, and there is a great deal more toxicity with ifosfamide, which is why bleomycin has remained standard therapy for patients with metastatic testis cancer. But even a negative phase 3 trial can be informative for individual patients. First of all, patients over the age of 50, bleomycin is a dangerous drug. Secondly, some of those patients I showed you with massive lung disease, bleomycin can cause scarring in the lungs, and those type of patients cannot safely get bleomycin. And then we talk about personalized medicine, and usually it has to do with genomic analysis of an individual tumor. This is Lance Armstrong, who is certainly the most famous testicular cancer patient. So when Lance Armstrong was diagnosed, he had noticed a mass in his testis for about 5 months, which he felt was occupational from being a long-distance cyclist, and it was only when he's having headaches and coughing up blood and having flank pain that he sought medical attention. And his x-ray didn't look as bad as those before-after, but it looked pretty bad, and he also had brain metastases at the time. So we had just finished and analyzed the data of BEP versus VIP. We hadn't even published it yet in a journal. And we told Lance that we can give him ifosfamide, more need for blood transfusions, more fatigue, but unlike bleomycin, it does not affect your lung function. Now, the overwhelming majority of young, healthy 25-year-old patients can take 12 weeks of bleomycin with impunity, with no effect upon any long-term career objectives. But if you're going to be a long-distance cyclist or a long-distance marathon runner, a slight decrement in your pulmonary function would end your professional career. So knowing that, and knowing that it wasn't going to lower his cure rate, he enthusiastically endorsed the idea of he's long since been cured of his cancer. And this is him winning the first of his 7 consecutive Tour de France's. So this is another athlete that is far less famous in this country, who tells me that his sport is the most popular sport in the world. Anyone have any idea what sport that is? And Yusuf, you can't answer.
Cricket.
Bingo, right. So his name is UB Singh. So he had a very unusual form of testis cancer that does not start in the testis, but starts in the middle of the chest. And this part of the body is called the mediastinal germ cell tumor. And I'll show you his picture in a little while over here. So he came to us. He kind of had a global route like Dr. Al-Khatib did over here, not as many countries, but he was from India, who was seen in the UK, and eventually wended his way to Indiana University, where the proper diagnosis and treatment was eventually given. So a couple of other pictures over here. This is John Cleland next to me when we had the 40-year anniversary for the first patient to be cured with testis cancer. And John's story is worth telling, and many of you perhaps know it already. He had just gotten married when he was found to have testicular cancer, and he was treated elsewhere with actinomycin D, had no response, was treated with a different chemotherapy regimen, had a brief 2-month remission, and then came to us for a clinical trial. So he was the first patient to get platinum and be cured of the disease. So we had no idea in 1974 that we could cure anyone with platinum or even improve their survival with platinum. But we did know a lot about platinum as far as the side effects. Platinum, as you know, is given for 5 days in a row. In 1974, we did not have effective anti-nausea and vomiting agents. And it's hard to imagine this, but on day 1 of a first course, the average patient would throw up 12 times and be terribly nauseated for several weeks, and then come back 3 weeks later for a second, third, and fourth course. It takes a great deal of courage to sign your name on the dotted line to be part of a clinical trial, knowing that it may not help you live a day longer, but may enhance a knowledge of platinum where nobody got cured, but it did have activity, and there was a rationale for doing this. And obviously this is really, it's not just doctors, but patients and their family members who change the course of individual diseases. And this is Lance Armstrong again. Who was also there for one of our 40-year anniversaries of successful treatment of testis cancer. So this is our cricket player, UB Singh. So this is a chest X-ray, and this is the area between the lungs called the mediastinum. So this is almost like a, this amazes me as a non-athlete when you look at people like Lance Armstrong and UB Singh. So Lance Armstrong was competing and being competitive in short distance races a week before he was diagnosed with massive pulmonary metastases. And cricket is a very exhausting sport, and some of the matches last for several days. And he led India to the World Cup final shortly thereafter because he was having more shortness of breath on exertion, got a chest X-ray, and this is what his chest X-ray looked like. He was still able to compete at a world-class level despite having that functional impairment in his lung. And here he is 1 week later. We got a chest X-ray 1 week later because he came back into the hospital with fever and a low white blood count, needing antibiotics and needing a follow-up chest X-ray, showing how rapid these drugs can work. Okay, so that was ancient history in the 70s and 80s, and this is where we are in 2019. As I mentioned, 60% of our patients will have good risk disease, the rest will have intermediate risk, or what we call poor risk disease, and this is progression-free survival, and this is overall survival. And we now cure, even with poor risk disease, almost 3/4 of these patients, not with first-line therapy, we're still about 50%, but because we can do high-dose chemotherapy with what's called peripheral blood stem cell transplant. So the concept of high-dose chemotherapy is, can we safely give 5 times the dosage of drugs whose main side effect is lowering the blood count, and do it relatively safely and give it back to the patient intravenously? So it's like being a donor to donate blood to a blood bank, but here you're donating blood to give back to yourself. So we actually started doing this back in 1986, and we went from bone marrow transplant in 1996 to peripheral blood stem cell transplant, where we didn't have to do a surgical procedure to extract the healthy blood cells, but we just get them from the blood, just drawing blood itself. So this is our first study that we did with this concept. These were all patients who failed to be cured. And to me, it is truly remarkable that we can give a drug like platinum and combine it with other drugs, infuse it intravenously, and cure overall 80% of all patients with metastatic testis cancer. But it's a miracle that we can take patients who are not cured with platinum and etoposide and actually give high-dose platinum and etoposide and still be able to cure almost 2/3 of these patients with second-line or even third-line therapy. And platinum refractory means that the disease higher dose of platinum and higher dose of etoposide, and we still, in this small sample size of 40 patients, cured 45% of them. We updated this data a decade later. We have a large number of patients from all over the world, of course, who come to Indiana University. And again, we are still curing about 2/3 of these patients with this concept of high-dose chemotherapy. And this is one of our patients with high-dose chemotherapy who rapidly progressed after BEP chemotherapy with extensive disease, massive disease in his liver, pretty critically ill, and long since being cured with high-dose chemotherapy in this setting. Okay, so I think that as patients, as family members, and again, as Yusuf mentioned, this is a family disease, not just a personal disease. I put down some guidelines that are for not just physicians, but for patients. Over 40 years of doing this, that I see that things are being done in my prejudice. I think that the only way to do this is the way we do it at Indiana University. But some things that are being done just simply are not correct. So first of all, I want to talk about sperm banking. There are no patients that should not be offered sperm banking before you start chemotherapy. You're 25 years old, your main thought is, am I going to die of the disease? Am I going to be able to survive the side effects of the chemotherapy? And the answer is yes and yes. And then all of a sudden you realize, I'm now getting married, my sperm count is 0 or so low, I can't father a child. Why didn't someone talk to me by a couple of days? But sperm banking should be mentioned. Not everyone wants sperm banking, but it should be mentioned. It's not always done, and I dare say it's probably not done at least 25 to 30% of the patients who are newly diagnosed. There is a tendency to, before a doctor even sees a patient and knows that they're going to get chemotherapy, to put in a vascular access device called a port or a portacat. It's not necessary. Young, healthy people have very good veins. It's short duration therapy. We only put in a vascular access device if someone has terrible veins and we can't get easy vascular access. The problem with a port is not just the expense and inconvenience. 10% of the time it gets infected. 15% of the time it causes a blood clot requiring anticoagulation with its own problems. So ports should not be routinely done even before the doctor sees the patient. Thirdly, PET scans. There is no value in doing a PET scan. Your CT scan tells you you have metastatic disease. It doesn't matter whether it lights up in Technicolor on a PET scan or not. A PET scan costs twice as much as a CT scan, and the insurance company, for once, is correct. It is not useful. Fourthly, and this is probably the most serious problem we see, when people get chemotherapy, no matter how strong, no matter how young, no matter how healthy you are, you come in 3 weeks later for your second course of therapy, and you're no longer looking strong and healthy and vigorous, plus your white blood count might be somewhat low. We do not delay therapy. This is a rapidly progressive tumor. You kill a percentage of the cancer cells with that first course. And as you're delaying therapy because someone's white count is too low or they look a little puny, those go right back in. So with rare exceptions, we try never to delay successive courses, and that's also true on the high-dose chemotherapy on our bone marrow transplant unit. Fifthly, we need to make sure that people are getting proper anti-nausea and vomiting medications. No one has 12 episodes of vomiting anymore, but there's a standard that should be used correctly in how chemotherapy-induced nausea and vomiting is treated. This is well established in many guidelines. A physician merely needs to look at the guidelines. Weekends and holidays. This has to be 5 days in a row of chemotherapy. If someone is starting on a Wednesday, they don't get treated Wednesday, Thursday, Friday, Monday, and Tuesday. You're delaying therapy. We have no evidence-based medicine that that's not harming patients. You need to have your office open on Saturday or Sunday, or even admit them for 2 days to the hospital if your office isn't open. We don't want to be delayed because of a holiday or because of a weekend. Again, as I mentioned. Fourthly, or fifthly, or sixthly, or seventhly, Yusuf, when I was looking at your slides, and we've talked before, Yusuf, with all due respect, you had good risk disease. So an HCG less than 5,000 puts you in the intermediate risk category. An awful lot of patients get a fourth course of BEP when we've already done a study of BEP times 3 versus BEP times 4 showing a 92% cure rate with 3 courses or 4 courses. So you don't want to be getting an extra course of chemotherapy. 3 is bad enough as it is. When bleomycin is given, it is given on day 8 and day 15 weekly. Bleomycin has a zero effect upon the white blood count. We never get blood counts when people are getting weekly bleomycin because it might confuse the nurse or the doctor to think, oh my gosh, the blood counts are low. It's always low on day 8 and day 15. And they might think, gee, I better not give bleomycin. And I would just add another bullet point over here, and Yusuf talked about his disease coming back with the teratoma 5 years later. Yusuf has been, Dr. Al-Khatib's been in our clinics now for a couple of weeks, and we've already seen several patients with disease coming back greater than 5 years out. Who sees 1 or 2 patients a year and probably never has someone relapse, doesn't realize that about 2% of patients will recur after 5 years. So we don't dismiss patients after 5 years. They're still seen annually. We get tumor markers. We do history and physical examination. We do well-adult type of checkups, make sure they're not smoking, that they're not overweight, that they have normal cholesterol, they don't have hypertension, they don't have diabetes, etc., etc. And we also realize the fact that when you are cured of testis cancer, 1% of testis, and yes, self-examination is important, but every now and then a physician will pick up something that the patient himself doesn't pick up. So these are some testis cancer guidelines. Now we talked a little bit about the acute toxicity of chemotherapy. This is the things that we worry about with long-term toxicity. The worst of these, of course, is second malignancies. So when people get etoposide, the E drug in BEP, 1 out of 500 will get acute leukemia. That's not high, but it's higher than the general population. Forms of common cancer, prostate cancer, lung cancer, bladder cancer, colon cancer, etc., which probably has to do with the platinum itself. Cardiovascular disease, again, due to platinum. These are late complications, hypertension, coronary artery disease, myocardial infarction. Pulmonary toxicity and nephrotoxicity really isn't much of a late complication. That's something that can happen during therapy. Neurotoxicity with numbness and tingling in the hands and the feet. Ototoxicity with ringing in the ears and decreased hearing are things that don't always go away with platinum. Low testosterone, I know you heard about this yesterday. I'll mention this in a few slides, and also fertility in a few slides over here. So this is something that has been known for a while that has to do with platinum. Platinum really is a miracle drug, and there is no reason to even remotely have fear of platinum. But 5 years later, 10 years later, 20 years later, if you take blood or do a urine analysis from a patient who has had platinum, you can still detect. That may or may not be why we see some of these late complications that can happen 5, 10, 15, 20 years later with cardiovascular disease and second malignancies. And this is a study from our colleagues in Europe looking at secondary cancers after curative therapy for germ cell tumor. This is a huge number of patients. Over 5,000 patients that were treated from 1976 when platinum was first available in the Netherlands. We started out in 74 up until 2007. And so we use this term of hazard ratio. And so there's a 1.8-fold increased risk of getting a second cancer because you had platinum, almost twice the risk. And that might sound very alarming, but let me make it into more simple terms. That means that you have about a 1 or 2% higher risk of getting cancer than if you never had chemotherapy and never had platinum at all. But it is 1 or 2% in a group of patients who are cured of their therapy. And so one needs to be aware of this. So radiotherapy is the same thing. We rarely use radiotherapy anymore in this day and age. But radiotherapy, average time from ending chemotherapy to get a cancer is 17 years later. And by the way, this is yet another reason why patients should be followed annually, well beyond 5 years, for just well adult checkups. I want to briefly talk about testosterone. You heard this yesterday. Most men know when they have difficulty having and maintaining an erection and they have fatigue to ask their doctor to check a serum testosterone level. It is best checked in the morning with normal circadian rhythm is 25% lower in the afternoon. That are less well known to patients are insomnia, depression, irritability, and anxiety. And when women go through menopause, they have have hot flashes. Men don't have hot flashes, they just have increased sweating and night sweats. So as a physician taking care of patients, we ask them about if they have any of those symptoms, and if so, we want to get preferably a morning testosterone level. Now, this is not just a quality of life issue, but this has to do with cardiovascular complications. Chronically low testosterone can lead, which causes insulin insensitivity, obesity in the truncal area, elevated blood pressure, elevated cholesterol and triglyceride, all of which can lead to cardiovascular disease. So this is data from our group looking at 491 consecutive patients. It certainly is not rare to have a low testosterone and be symptomatic, as we can see on this slide. And having low testosterone and being symptomatic leads you to a variety of other type of problems if not treated with replacement testosterone. Now, there is something new that I don't know anything about yet because it hasn't yet been released by the FDA. But when someone needs testosterone, testosterone is not orally absorbed by the gastrointestinal tract. So your options are once a week or once every 2 weeks or once every 3 weeks injection, making a little incision and putting a testosterone pellet that can be good for 3 or 6 months, using a gel that you put on once a day, using an underarm preparation called Einhorn, and now there is a new oral treatment. I have not used this myself for January or February. It has a name I can't pronounce by a company I know nothing about. This may be a more palatable way of giving replacement testosterone, if indeed the data really seems to be effective. So what about concerns about testosterone? So first of all, there is no need to be on testosterone as we all age. All of our testosterone, all those symptoms that I mentioned with erectile dysfunction and fatigue do get worse as we get into our 50s, 60s, and 70s. We treat patients with hypogonadism when they have symptoms and a low testosterone, not just because they have symptoms alone. Does testosterone replacement cause prostate cancer? Of course not. Does it cause liver disease? No. Does it cause a high red blood count that can cause blood clots? Yes, it does. And so when people are on testosterone, we periodically check their blood counts to make sure they don't have a high red blood count. And if they do, we either lower the dose, stop the dose, or we do what's called a phlebotomy, where we take out some of their blood. It's like they're given a blood transfusion when they don't want to give a blood transfusion. And there is what we call financial toxicity. My nurse, Jay Bowdy, probably spends more time talking to the insurance agents about getting replacement testosterone covered, even when people have both testes removed, than he does taking care of patients with his day-to-day activity. But this is life in the American healthcare system. Now, fertility I know was covered also. Again, we offer for sperm banking to all patients. If you've had to go through high-dose chemotherapy, your chance of spontaneous sperm recovery is about 1%. If you go through VEP chemotherapy, 60% of them will recover. Their sperm count will be normal. There's no increase in birth defects, but it takes at least 1 year for your sperm count to recover. You may know this already, but when sperm banking is done, you're more likely to have twins. Our urologists are very adept at doing a nerve-sparing retroperitoneal lymph node dissection, so you don't have retrograde ejaculation. And perhaps many of you know already that if you are on replacement testosterone, decrease your sperm count. So there are other alternatives that can be done instead of replacement testosterone. Nephrotoxicity, not much of a problem. Peripheral neuropathy, that numbness and tingling, those are the annoying problems that we get with platinum. The older a patient is, the more platinum they get, the more severe those type of side effects can be. Cardiovascular, we talked about already. And I'm going to skip this for the sake of time over here. Excuse me. and talk about something that's brand new. And this is what's called your testis removed. You have embryonal carcinoma with what's called vascular invasion. Your HCG and AFP are normal, your abdominal CT is normal, your chest x-ray is normal, so you have stage 1 disease. You see the oncologist for your first visit, and your oncologist is going to tell you that although all your studies are normal, with embryonal carcinoma and vascular invasion, you have a 50% chance you have metastatic disease somewhere in your body. And so here are the 3 options. We can have you on surveillance, and yes, if the cancer comes back, and it will 50% of the time, you will then need 3 courses of BEP chemotherapy. Of course, it's going to cure you. Or we can have a good urologist do a nerve-sparing retroperitoneal lymph node dissection, because that's the most common place of disease. Or we can give you 1 course of BEP chemotherapy, which of course goes everywhere in the body. And patients and doctors agonize about those choices. MicroRNA 371 may be capable of making those easier decisions, because this may be allowing us to pick up something, and it has a very high sensitivity and specificity, meaning that when the microRNA 371 is elevated, over 90% chance there is disease somewhere in your body that you just can't see on the x-rays. And when the microRNA is negative, despite a 50% probability of having cancer, there's less than a 10%, less than a 5% probability that you really need to have any type of therapy. We also are looking at this on patients who have seminoma. They're treated with chemotherapy. A 10-centimeter mass becomes a 5 centimeter. I'll be able to use to be more definitive as far as that yes or no answer. So I'm going to end with looking at what can we do to prevent late complications, because we're not going to go back to the actinomycin D era where we were no longer giving platinum chemotherapy. So we no longer advocate radiotherapy for anyone with clinical stage 1 seminoma. We don't want to give people 4 courses of BEP if 3 courses of BEP is going to cure their disease. We want to be aware that cardiovascular complications can happen at a higher rate because of platinum. They can be prevented in some situations: smoking cessation, weight control, cholesterol and triglyceride control, blood pressure control, and knowing about testosterone and metabolic syndrome. Fertility, we want to be aware of the fact that our patients are aware if they need an RPLD, and fertility is important. You want to have a urologist who knows how to do a nerve-sparing RPLD, and sperm banking pre-chemotherapy, and again, long-term follow-up for all the reasons that I mentioned above. This was a very popular book by a person who was an oncology fellow at Dana-Farber in Boston, Dr. Sid Mukherjee, called The Emperor of All Maladies, and Ken Burns did a TV series on this in PBS about 3 years ago. Just quoting this, which you can read yourself: in the end, cancer truly emerges as a 19th century surgeon once wrote in a book's front piece as the emperor of all maladies, the king of terrors. Well, that certainly was, and perhaps still is true, but not as much in 2019 as it was at the end of the 19th century or even at the end of the 20th century. So this is what survival curve looked like before platinum was around. If you had stage 3, which means pulmonary metastases, testicular cancer, you had a 90% chance of dying within 1 year of diagnosis. If disease has spread to your lymph nodes with stage 2 disease, you had a 50% chance within the first 2 years of dying of disease. So these are the statistics now in Indianapolis and Denver worldwide, that those patients that present with disease confined to the testis, virtually all of them will be initially or subsequently cured. If disease has spread to the retroperitoneal lymph nodes, almost all of them will be cured. And even in the presence of metastatic disease with first-line or second-line or even third-line chemotherapy, 80% of these patients are cured. And so overall, 95% of these patients will be cured. And I want to end with just 2 final slides about platinum. So how did platinum come about? It really is a very interesting story. So a biophysicist at Michigan State by the name of Barnett Rose in the 70s was playing around with physical agents. And that included something called hyperthermia, where you heat up the tumor cells and try to get better effects with radiotherapy or chemotherapy, or believe it or not, electrolysis. And so what he did, he set up a biological system where he had like a little aquarium filled with water, and he dumped E. coli bacteria into that water and ran an electric current to see what the effect of that electric current would be upon replicating E. coli. And he found this very interesting biological effect that really changed the DNA structure of the E. coli, and he was clever enough to realize how in the world can a simple electric current for a few seconds have such a profound biological effect. And as they say, serendipity favors the prepared mind. He was clever enough to realize maybe it's something from the electrodes, not the electric current, going into that water bath solution. And you guessed it, they were platinum electrodes. That's how platinum came about. So when you have a brilliant idea, and about 90% of brilliant ideas don't work, or animal models, and platinum was used in showing a broad activity across many models, and now you're ready to put the first human on it. So 1972 was when platinum was first used. As I mentioned, it caused horrendous nausea and vomiting, and it was used in disease where the drug had no activity at all in heavily pre-treated patients. No one was smart enough to intuitively know what it was going to do in testis cancer. And if you were able to take it for a second course, a third course, a fourth course, you were getting kidney damage, you were getting neuropathy. It was felt that the side effects of platinum greatly outweighed the therapeutic advantage. And just as platinum has saved the lives of hundreds of thousands of young men with testis cancer saved platinum. This drug would not be here 45 years later, except for the dramatic results in platinum. Now, most drugs that we use, especially chemotherapy drugs, they don't have legs, they come and go. Well, here we are in 2019, 45 years after the first patient was treated with platinum chemotherapy, and some of which are curable, all of which have palliation of symptoms and significant prolongation of survival. So with that, I will end, and thank you very much for your attention.
How are you on time? Are you okay?
Oh yeah, I'm fine.
Okay.
Yeah.
A question on Facebook Live.
Oh, too late.
Okay, all right, fine. Saveda Kadar asked, what is the success rate of immunotherapy for testicular cancer?
Sure. So immunomelanoma, kidney cancer, lung cancer, Hodgkin's disease, head and neck cancer, esophageal cancer, cervical cancer. We looked at immunotherapy trials at Indiana University of people who were not cured with high-dose chemotherapy on the bone marrow transplant unit. We saw zero activity. So immunotherapy is not a panacea for all cancers. It has absolutely no activity in testis cancer. So testis cancer is an old-fashioned disease. You know, we're moving away from chemotherapy. Drug development is agents looking to see what is driving the progression of cancer and developing a monoclonal antibody or drug to block that. So chemotherapy is treatment from the 70s and 80s, but testis cancer remains a pure chemotherapy disease, and immunotherapy unfortunately has had basically zero activity, unlike its dramatic effects in so many other types of cancer. Yes?
So if you finish your 5 years of follow-up,
Right.
and then you go to your primary care doctor, how can you, as a patient, be your own and what that you should ask for? And we got a little information from Dr. Costa yesterday that I thought was really, I was like, wow, that's really important to know.
Right.
What are the best things you can do to be your own best advocate?
So there are what are called survivorship plans, and I would tell you that a busy doctor who's seeing patients every 15 minutes isn't going to look at a survivorship plan every 15 minutes for kidney cancer, lung cancer, testis cancer, multiple sclerosis, or any other non-malignant disease as well. So if you have had chemotherapy, once a year you need to get your tumor markers, HCG and alpha-fetoprotein. So these 2% of patients that have a late relapse beyond 5 years due to cancer, the great majority will have a rising serum alpha-fetoprotein when they are completely healthy with no symptoms whatsoever. And that will prompt investigation, and you will find a small lymph node, usually in the abdominal area, that is going to have an extremely high cure rate with surgery. So that's the most important thing. Number two, and the primary care doctor knows this already, but he doesn't know about the alpha-fetoprotein. You should have a routine, well-known history and physical examination, but that history and physical examination should include asking, Are you having pain or swelling in the remaining testes? And that should be part of the physical examination, because yes, you can do your own physical examination, the self-examination, but it's good to have a second party examine and make sure there's not, I always tell patients when they're doing self-examination, it's like feeling a clenched fist. You take your second and third fingers and it feels firm, but then you hit your knuckle, and that's what you're checking for. If you have a testis replaced by cancer and it feels like a solid rock, a medical student can easily recognize that. What you want to do is pick up that small little knuckle when it's still very in the center. You need to be aware as a chemotherapy patient that you are at risk for these other late complications. So part of what a good doctor will be doing is asking about smoking, checking weight, checking blood pressure, checking cholesterol, and asking about symptoms of low testosterone. And if a low testosterone is present and a patient is symptomatic, again, trying to prevent some of the cardiovascular complications by being on replacement testosterone. So a good internist may know that already, but a good internist probably doesn't know about the only testis cancer patient that internist has seen that entire year. And it's not fair for the internist to think to be an encyclopedia of knowledge or to be looking things up in a guideline or a survivorship plan every time that he's seen a patient. Now, Dr. Apatib has been in our clinic for 2 weeks now, and we've seen, 4 patients already who have had late relapse beyond 5 years because their oncologist didn't know about checking their tumor markers on an annual basis. And so they now come in with extensive disease, no longer that. When you have a late relapse, you are only curable with surgery. We don't cure late relapse when it comes back more than 5 years later with high-dose chemotherapy in the bone marrow transplant unit. So that's why you want to pick it up when someone is healthy with no symptoms, has the elevated alpha-fetoprotein, you find a small lymph node, rather than they're coming in with chest pain and coughing up blood and having massive pulmonary metastases and abdominal disease with an alpha-fetoprotein in the hundreds of thousands where there's where you can help the patient, but you cannot.
Notice you did mention clomiphene in the testosterone.
Right, and so I sort of semi-mention it because clomiphene is what you do want to use if you want to be on something to relieve the symptoms of hypogonadism but preserve fertility. So I am not a fertility expert. I can't even begin to have the expertise of the people who talked yesterday, and I wasn't here yesterday. We have people who are experts at Indiana University dealing with this, but clomiphene is used instead of testosterone, but certainly during that time period, testosterone is what we tend to use. And again, the patient sort of chooses, do they want the gel, do they want the injection, do they want the underarm preparation? And I have no idea about whether a study has ever compared the effectiveness of clomiphene to testosterone, but we do know that clomiphene is going to allow you more likely not to have a reduced sperm count because of the testosterone itself.
What are other side effects of clomiphene?
I have no idea. And I also don't know what the cost differential is with clomiphene compared to testosterone, or whether insurance routinely covers it or not. Good question, though. I don't know if anyone else knows the answer to that.
Another question on Facebook Live. Selena Myra asks, what is the best plan when teratoma continues to grow after 5 years?
Okay, find a good surgeon. We're very blessed at Indiana University. We started off with John Donahue in urology, then Richard Foster in urology, and now Clinton Carey and Tim Masterson. And we have the greatest thoracic surgeon in the country with Ken Kessler. We monthly see patients that have masses that cannot be resected at major academic centers, and we resect them and we cure them at Indiana University. It's not something surgeons are used to dealing with if they're not testicular cancer surgeons. So we'll see people that have 15 centimeter masses in the abdomen, encompassing the aorta, where you have to do an aortic graft or replace the inferior vena cava. That is inoperable in many places, but operable there, because if it is teratoma, there is no medical treatment that will make teratoma go away. It is surgery. Now, we cure the great majority of them with growing teratoma. Now, if someone has growing teratoma in multiple parts of the body that defy surgical removal, there is a drug available that will not cure your disease, but will slow its rate of progression. And this is referred to as a cyclin D4/6 inhibitor. There are several that are out there commercially available for breast cancer, but the reason why they work in growing teratoma will have overexpression of something called the retinoblastoma gene. This drug blocks the retinoblastoma gene, so you can see patients that are just getting bigger and bigger and bigger unresectable teratomas, and will just stop growing for a couple years. But eventually, like is true with many drugs and many diseases, the drug stops working and it will continue to grow. But it can buy a couple of years of productive life with very minimal side effects. So this is one of the rarest of the rare situations where we have teratoma that cannot be resected. There certainly are common situations where teratoma cannot be resected in an individual hospital where it can be in a.
Did you have a question?
I did.
Yeah.
So, what's the difference? So, would there be a reason to only receive 2 cycles of EEP instead of 3 cycles?
So that's a question I get asked by patients about disease. So we did studies, as I mentioned in the talk, where it used to be that everyone got 4 courses of therapy. And so we felt that for the good risk patients, that's 60% of all patients with metastatic disease, maybe we can cut those last 3 weeks, or cut that last 5-day course of platinum, because the more platinum you get, the more ototoxicity, you bring in the ears and hearing loss and peripheral neuropathy and even potential for kidney damage. So we scientifically proved that 3 courses or 4 courses gives you the same 92% cure rate. I have been reluctant to carry that one step further to 2 courses versus 3 courses, because we felt logically that 3 courses may be an optimal duration. 2 courses may be paring it down too low. So the advantage is you're getting 1 less. 4 courses was pretty rough, but giving 2 courses instead of 3 courses may be just as effective. But on the other hand, if it's not, you're looking at high-dose chemotherapy in a bone marrow transplant unit to try to cure your disease. So we do not advocate giving anybody with metastatic disease 2 courses of therapy, no matter how low their HCG and AFP are, and no matter how small their metastatic disease is. But there is no data for or against doing that, but we are concerned about doing that. Again, the goal is cure. We don't ever want to jeopardize. Well, did you have stage 2 where you had visible disease in the retroperitoneum?
No, it was only confined to the 1 test.
Yeah, so that's different.
Okay.
We would have recommended 1 course of PEP. So let me go a little farther. So this is what I mentioned before about microRNA 271. So when you have vascular invasion and you have a carcinoma, you have a 50% probability of having recurrent disease. That's what we call high-risk clinical stage 1 disease. Scan larger than 1 centimeter in size. And if you have lymph nodes larger than 1 centimeter in size, that's metastatic disease. So if you wanted to give prophylactic or adjuvant chemotherapy to lower that 50% chance of recurrence down to 1%, because chemotherapy goes everywhere in the body, 1 course of BEP chemotherapy can do that. Now, in the guidelines, it will tell you, and these are guidelines that are national and international, that options for clinical stage 1 high-risk disease can be surveillance, can be having a good urologist do a Durasberry and RPMD, or giving 1 or 2 courses of BEP chemotherapy. I personally don't see the logic of giving 2 courses when you're having a 98, 99% success rate with 1 course. It would be impossible to ever prove that that 2nd course is necessary. So this is what we do. I would tell you that in our center, more patients probably choose surveillance and they choose to have an RPMD or 1 course of BEP. These are hour-long conversations going over the pros and cons of each approach. And without, we tell patients that if we knew that they had 1 microscopic lymph node in the abdomen and nowhere else did they have disease, we want to remove that with an RPMD. We also tell patients they also have 1 microscopic cancer cell in the lung. We want to give them 1 course of BEP chemotherapy, which works everywhere in the body. And if we knew they had no disease anywhere in the body, they wouldn't even need surveillance at all. And microRNA is not going to change that template. It just is going to refine that template. And so if I be able to tell someone who thinks they have a 50% chance of recurrence, and they have, I only have a 5 or 10% chance of recurrence, and I might be more comfortable with surveillance. vice versa, that they have an elevated microRNA 371, less comfortable with surveillance knowing that. But it's a tool that is still in its implementation stage. So we have clinical trials looking at that hasn't been what we call prospectively validated as an instrument to make therapeutic decisions. Yes, I'm sorry, I'll go to you next.
Could you just talk a little bit about the tumor markers, the
Alpha fetoprotein.
protein, in terms of, so you've had the surgery, you've had a reoccurrence, you've had the surgery, that's been removed, but the markers still stay elevated, but
Right.
the scans are clear. Does that still mean that there is remaining cancer usually, or
So,
markers go down?
and of course, that's a very sophisticated question, and it's hard to cover every little contingency that happens. But most laboratories will list alpha fetoprotein as 0 to 8 being normal. And I can absolutely guarantee every person in this room, including women, that lots of people have alpha fetoproteins in the teens, who never have cancer, never will get cancer. And so we started doing studies with platinum in 1974, and we always listed 0 to 25 as being normal. We will see patients referred to us for recurrent disease because after chemotherapy their alpha fetoprotein is 15 or 16 or 17. And we tell them there's nothing there at all as long as it's below 25, and they're followed for 5, 10, 15 years. So an AFP less than 25, regardless of what the lab lists as normal, it's normal. Now what if it's above 25 and rising? That's trouble. So what we would do is we would have a different lab do it just to make sure they're not having a bad laboratory with their reagent, and it's still rising. So the first thing we want to do is check a blood test for liver function. So if someone has some degree of liver disease, either drinking heavily or subclinical hepatitis or some degree of liver problem, alpha fetoprotein is produced in the liver. And this is an easy differential because you would have elevated blood tests which have to do with the function of the liver. It's called an AST or an ALT. So that could be the cause of the rising alpha fetoprotein. The next thing we want to do is do an ultrasound of the other tests, because 1% of patients will get a second primary, and rather than looking at more chemotherapy, it may be that the source of the rising alpha fetoprotein is in the opposite testis. And of course, we're doing the chest, abdomen, and pelvic CT scan. But a rising alpha fetoprotein in the absence of a bad laboratory means that there is embryonal carcinoma or yolk sac tumor somewhere in the body. And sometimes it takes a long time to find. And an example of that is our late relapse patients. So we have patients who are out beyond 5 years. Someone comes in 8 years out, they're perfectly healthy, they get their tumor markers, physical examination, and history, and at the end of the day, I look and oh my gosh, the alpha fetoprotein is 150. And so we have it repeated the next day, and it's 160. We do all of these tests, and everything is totally normal. Sometimes it takes a year or two with late relapse to find where that small little lymph node is that's secreting alpha fetoprotein. And I always tell patients with late relapse, no one dies because of a number on a blood test. You die because of volume of disease. And sometimes it's nice to have that alpha fetoprotein. And sometimes you have that rising alpha fetoprotein, you're out beyond 5 years, and it takes a while to find it. We just do serial imaging studies until we find where the disease is. But when someone is in their first year of follow-up and they have a rising alpha fetoprotein, that's bad news because they're probably going to need salvage chemotherapy or salvage surgery with alpha fetoproteins. Yeah.
When you have to the lymph nodes in the abdomen, and you've done 3 rounds of EEP, where do you what's your decision based on what the tumor looks like if you're going to do the
RPLD?
Yes.
Sure. So if you have seminoma, and the larger the seminoma in the abdomen, the less likely it is to ever go away with chemotherapy. So we hope hardly ever in seminoma because that residual mass is almost always going to be dead scar tissue. And it's a really complicated surgery. It's like cutting through cement. And the reason why seminoma lymph nodes don't go away is they're surrounded by a rim of scar tissue medically we call this a desmoplastic reaction. So the seminoma disappears, but that rim of scar tissue still remains. So if it's seminoma, we'll do serial CT scans to make sure it's not getting bigger. Now, if you have non-seminoma, which means you have a rhinocarcinoma in the testis, yolk testis, and your residual lymph nodes are greater than 1 centimeter in size, we go ahead and have a good urologist do a post-chemo RPL&D. We don't do it if lymph nodes are visible and less than 1 centimeter in size. And to give you data, so if you have teratoma in the testis, and you start off with a 5 centimeter retroperitoneal lymph node, and now after chemotherapy it's a 3 centimeter retroperitoneal lymph node. When we do a post-chemo RPL&D, 80% of the time that lymph node that you're going to remove is going to be teratoma. The other 20% of the time is dead scar tissue. What happens if you leave teratoma alone and don't do that surgery? It can slowly get bigger, bigger, and bigger, and a relatively easy surgery can become a very complicated surgery. And then sometimes it can grow more rapidly and morph into other types of tumor. Now, conversely, if you have that same 5 centimeter mass, it becomes a 3 centimeter mass, and the testis has only embryonal carcinoma, no teratoma at all. We still do the surgery because 40% of the time is still going to be teratoma. So a post-chemotherapy CT, but it won't tell you whether it's dead scar tissue where you don't need to do the surgery, whether it's teratoma, and we can tell you the percentage of probability of teratoma, and maybe 1 or 2% of the time it still might be cancer, even though that HCG and AFP have returned to normal. So unless there are compelling medical reasons for safety for putting someone to sleep under a general anesthetic, if there is non-seminoma in the testis and a persistent larger than 1 centimeter mass and the markers are normalized, we always recommend going ahead and have a good urologist do a retroperitoneal lymph node. Yes, seminoma means it's 100% seminoma. Okay. So if you have 95% seminoma and 5% embryonal carcinoma, that's non-seminoma. Yeah.
Question on Facebook Live. Melanie Commons is asking, what is the prognosis and treatment for late relapse after adjuvant BEP?
Well, that's a good question because we've never seen that. So adjuvant BEP implies that someone had clinical stage 1 disease and opted to get 1 course of BEP to lower that relapse rate down to 1 or 2%. So late relapse we define as greater than 2 years out, but usually greater than 5 years out. So when I say that we don't cure patients with chemotherapy when they have a late relapse, that's when people get a full 3 or 4 courses of BEP chemotherapy. If someone is chemotherapy naive, has never had chemotherapy, just surgery, and they have a relapse 7 years later, they're still easily cured with chemotherapy. I have no idea what it is when someone gets 1 course of chemotherapy. We've probably given 1 course of adjuvant chemotherapy. None of the 20 have ever relapsed, but some of them will relapse. But there is no information as to how easy or how difficult it is to cure if the cancer comes back that first year or if it comes back 7 years later after 1 course of BEP. But we would take the optimistic rather than pessimistic point of view. If someone has a localized late relapse that a surgeon can remove localized disease, that would be our preference. If they have generalized disease, we would treat them with 3 courses of BEP, which would take them up to a total of 4 courses of BEP, assuming that they're under age 50. Yeah.
To add to that, I wanted to see your thoughts on if a patient with clinical stage 1 seminoma insists on adjuvant carboplatin. Do you still use 1 cycle, or would you go 2 cycles with the, I've asked you before, like a year ago, with the Swinneteca data?
Well, my answer is probably still the same. So with seminoma, the risk factor for having microscopic disease in the abdomen is the size of the tumor. So if your tumor is less than 4 centimeters in the testis, you have a 95% cure rate with orchiectomy alone. If your tumor is larger than 4 centimeters, you have an 80% cure rate with orchiectomy alone. And conversely, a 20% probability of having microscopic disease in the retroperitoneum. So if one were to get radiotherapy prophylactically, or one were to get carboplatin, single-day carboplatin prophylactically, that 20% will go down to 6%. Now, there is no logic or evidence to remotely think that 2 dosages of carboplatin is better than 1 dose of carboplatin, same as with 2 courses of BEP versus 1 course of BEP for clinical stage 1 non-seminomatous germ cell
Oh.
tumor. So why do the co-agenti in the testicular cancer field worldwide not recommend carboplatin and not recommend radiotherapy? Because yes, it's nice to go from 20% to 6%, and this has to do with late complications of therapy. And yes, the incidence is only 1 or 2%, but that 1 or 2% can cause problems that are not curable in a disease that is eventually 100% curable. And just as cisplatin remains around 5, 10, 15, 20 years later, carboplatin's a platinum, and there's no reason to think that you're not going to have the same type of issues over there. So we never look back. What's been done is done. It's not wrong to do radiotherapy. It's not wrong to do 1 day of carboplatin. It's not wrong to do a second course of carboplatin 3 or 4 weeks later. It will not eliminate the need for surveillance, because you still have that 6% chance of recurrence instead of 20% chance. You're doing the same type of surveillance you would be doing anyway. You've just lowered by 14% your probability of needing subsequent therapy. Now, in our seminoma patients, when someone relapses on surveillance, we try to avoid radiotherapy. We try to avoid chemotherapy when they have metastatic seminoma. And the majority of them will have a small lymph node in the abdomen. And we have our very good urologist just do a retroperitoneal lymph node dissection. They're in the hospital for 2 or 3 days. There's no late complications from that. So that's why we've gone away from arguing about should it be radiotherapy 1 day of carboplatin or a second one 3 or 4 weeks later. But I would tell you that in our patient population, we have patients who are not comfortable with surveillance. So we have dialogue, we present data, we present perhaps our somewhat prejudicial viewpoint of what should be done. But if they want treatment, be it radiotherapy or with chemotherapy, we say fine, and we're following them and doing the same type of follow-up as if they were on surveillance.
Thank you.
In regards to follow-up CT scans and chest X-rays, is there any consideration for someone who's been exposed to a lot of radiation and getting, is it
MRIs,
right?
Sure. Yeah, we get that question a lot because about 5 years ago, it was very popular in the medical and non-medical literature, wondering about whether CT scan modeling from radiation exposure with Hiroshima and Nagasaki, and it's going to be the same thing with Chernobyl in a more recent time period over here. So radiation can cause cancer, and that's why we worry about radiation therapy for patients. But that's a very different model than doing an imaging studies. And by the way, there's a different type of radiation that we know increases the risk of cancer, and that's in astronauts. So being out in outer space, and it's primary lymphoma, there's a significantly higher incidence of that. So it's not something data rather than hypothesis. So at Indiana University, we were one of the first places to have a CT scan. This was back in 1975. So we have 45-year follow-up on patients. In fact, it's 75. Yeah, 45-year follow-up on 55-year follow-up on patients who have had a 45-year who have been treated with CT scans. And the Canadians have looked at the same experience also. So if serial CT scans is going to increase cancer, we will see an increase in leukemia. There is not. We will see an increase in lymphoma. Yes, there is increase. For whatever reason, there's been a steady increase in non-Hodgkin's lymphoma. It hasn't gone up more steeply, but it's still going up somewhat. We will see an increase in bladder cancer. We don't. Stomach cancer, we don't. Colon cancer, we don't. With prostate cancer, when screening PSAs were very prevalent, there was an increase in incidence of prostate cancer that's PSA related. Now it's gone back down since PSA is so routinely done in older men as far as a screening tool. So our major journal is called the Journal of Clinical Oncology. And in the Journal of Clinical Oncology, the Canadians did a great study where they looked at several thousand patients treated in the 70s and 80s, followed sequentially to look for second malignancies who were cured, obviously, of testis cancer or getting serial CT scans over a 5-year period of time. And they looked at what's called an age-matched control. So these are not testis cancer patients. These are just brothers, relatives, or people who have the same characteristics, the same age, but don't have cancer, and have never had a CT scan ever. And yes, as people get older, they get cancer. Cancer is a disease of aging, testis cancer notwithstanding. There was no evidence of any increase in other malignancies in the group that had CTs versus the group that didn't. That then prompted a letter to the editor by someone saying, you can't say that after just 20 or 30 years, you have to look at 50 years.
Mm-hmm.
So people do ask for an MRI, and if we go over this data with them, if they want an MRI, we're happy to do so. An MRI is twice as expensive as a CT scan. It's almost always covered by insurance, but it's twice as expensive. Those of you who've had an MRI know you're in that tube for 30 to 60 minutes. If you have a little claustrophobia, it's a little bit more uncomfortable. But when MRIs were brand new and patients were getting a retroperitoneal lymph node dissection, we did a study where patients got both a CT and an MRI to see whether an MRI would give us better detail. So an MRI is neither better nor worse than a CT scan. So we have that data. If we want an MRI, it's not going to be better, it's not going to be worse. It's just going to be a little more uncomfortable, a little more expensive. And if you are worried about radiation exposure, and again, we don't trivialize people's worry. There may be some small segment of the population who has some susceptibility to radiation exposure that can get a second cancer because of CT scan. It's just that it's hard to find who the person is with the data that we have that I mentioned. Yes?
How soon will the new whatever it was that you
Oh, the microRNA?
be released in what?
So it's still experimental. So
Okay.
this is being done both in Europe and in our center and in Canada. So I would say what you need to have is longitudinal follow-up. Yeah, so if you are going to do an RPLD, you get immediate follow-up as to whether you have positive or negative lymph nodes when you had a normal abdominal CT scan. But most of the time you're looking at newly diagnosed stage 1 patient. You have a negative microRNA. Are you comfortable there's no cancer there? Well, you need several years of follow-up. You need a large enough number of patients. So I would say that it will be at least 2 or 3 years from now before that will be a commercially available test. And again, I think it will add to our armamentarium. It will never be 100% effective. That sensitivity specificity of 91% and 94.6% is really good. There are very few tests that have such a high sensitivity and specificity for when it's positive there's cancer, when it's negative there's no cancer. But it's not going to eliminate surveillance because whether you have a 50% chance or a 4% chance, you still want to make sure that you pick it up at an early level. But I think the microRNA 371, I think there's enough data to know that it's promising, but it's not enough data to know that it's absolutely something that should be part of everyone's treatment algorithm at the present time.
All right. Round of applause, Dr. Einhorn.